That's very loud. Good morning. Well done. Congratulations. This is the most intrepid few from the whole of One NHS Finance, I think. Brilliant. So there's a few of us here this morning to talk to you about AI and predictive analytics. So I think we heard a bit yesterday about robotic process automation, use of bots. I think some of the things we'll talk about today kind of try and take that to the next level and start to drive either operational or financial performance. We think they're really interesting, they're pretty practical, they've been used in reality. So we're going to talk about three things. So Alice is going to talk a bit about using IT and AI to help with contract management, and then Jenny's going to talk both about population health management and also the use of AI in operational performance. So I think really exciting session for us. I'm Stephen Farrington Bell, partner at PA. I lead a lot of our health economics and finance work. My colleague Alastair and Jenny can introduce themselves as we go through. So that's what we're doing. This is who we are. Come and say hello afterwards. We always love to chat. So as I say, welcome intros, three areas, and then we'll do a Q&A. The Slido is still operational. It's already had questions in, so get them in quickly. There's a mad rush. Because we'll talk about this a bit afterwards. We'll keep the presentations fairly short as well. I'm sure attention spans are being challenged this morning slightly, so we'll try and keep it punchy. So why are we here? I mean, I'm not going to relabour the point about financial situation, run rate, financial performance, balance, or anything like that. We're here for the reason I kind of said, which is, can we use some of these new technologies, can we use the opportunities of digital and AI to really make a difference in both the operational performance, the quality of services, and ultimately then the kind of financial position for the NHS. And they're, as I say, real things that have actually been done either in the NHS or more widely. So this isn't a kind of conceptual thing about using ChatGPT to tell people what medical diagnosis they need. It's real stuff that has been used either in an NHS trust or in another industry. And by the end of it, you'll know all about AI, you'll be experts, you can go back and explain to everyone the great potential of AI and modern technologies to make a big difference. So why don't we just crack on? Alastair, do you want to talk to us about contract savings?
I'd love to, Stephen, thank you. Good morning, Alastair McAulay. I think I'm IT transformation expert, which really means for the past 25 years, 25 and count them, at PA, I've been doing things like negotiating service provider contracts for IT services, reorganizing how the IT function works, all in the name of being more efficient and allowing the business to transform itself and do things they couldn't do before. So I've done work for a variety of organizations. I've done work with NHS England, Scotland, Wales, and hospital trusts and so forth, but I've also done quite a lot of work for other outside organizations in the public sector, like National Rail, and in private sector. So quite a few large organizations in there. And the starting point is for this talk is really that a lot of IT is pretty generic. It's commoditized stuff. You know, a laptop is a laptop. Frankly, a data center is a data center, and the servers in it, they're all running pretty standardized stuff. And the services used to support that are also fairly generic and standardized. There's an open market for it. It's easy to compete for it. Actually, if you need to retender, it's actually fairly straightforward. There's very little, and I would say 75% is generic, but so the remaining 25 is probably stuff which is locked into the specifics of your organization. That's the bespoke applications that you can't just lift and shift and share easily with other organizations. And that's really the starting point is that when you've got generic commoditized IT, there's a great opportunity for sharing it or actually competing for it and doing things, pulling levers to reduce costs. And cost savings we've seen, of the addressable cost savings, they're at the 10-20% per annum. And in the context, certainly, of the ICSs that we've been working with so far, there's 100 million spend in some of the ICSs we've been looking at, as you well know. So, 10% of that's sizable numbers. So how do we get at that? What's that going to mean? areas where, the levers I talked to, where you can reduce costs. Well, firstly, they're up here. I won't read them out, but I'll illustrate with a few examples. We find when we look at organizations, this is organizations in general, I'm not picking on any one ICS organization or a health NHS organization, but in general, if you look at the portfolio of service contracts out there, there's often overlap and duplications. We recently went in and did an assessment with a bank, and they're paying for 2 identical services. In this case, it was a data center. The data center facilities were providing a suite of services, and it engaged a third-party supplier to run the infrastructure in it. And actually, there was some duplication of services, and they were paying twice for it. They're paying twice for what's called the remote hands, the people who will run out or get into the van and go onto the floor and fix something. There was 2 identical contracts. And because they get negotiated at different times, it's just, well, nobody looks and stands back at the bigger picture, and there's overlaps. Over-ordering, I mean, that's a big deal with licenses. It's easy just to keep ratcheting things up. Nobody's complaining, but actually when the demand goes down, you get stranded with too many licenses. This is probably a similar story with obsolete contracts. And I think the thing you see here, several or more than one occasion, is, the project comes along, the transformational project comes along, the new system is built, but the old one isn't switched off. And it's not switched off for a very good reason. You might need to fall back. You might need to go back and get the data that was forgotten or do something. It's contingency. And then the project gets wound up and you forget to turn off the old system. And, they're paying money for that. I mean, probably in a regulator organization, they were paying something like, when we went in and looked at it, they were paying something like, it was about 20K per month on an obsolete system, which then again is 200K per year, and that was completely redundant. So, this is the sort of sums. They're not necessarily in themselves any big, massive sum, but cumulatively they start to add up. The other one actually, which I put in there, the overspecified service levels, where, everybody goes in and asks for gold because everything's very important. But there's a nice nuance here that we picked up actually with Network Rail last year, where in Network Rail's case, and it probably applies to your context quite a lot, there's a lot of remote locations where you have to deliver services to, in your case, be surgeries and things like that, where there are networks set up to communicate. And actually, the networks now are completely overspecified because of the rise of things like 4G and 5G, means that if something goes wrong, you don't need the man in the van to come out at an hour's notice to repair something because, well, you just turn on your mobile phone and tether your laptop to it. And, so therefore, the service level is now inappropriate for what technology can do. And actually, we were just talking to an IT director in ICS last week, and he said, you're absolutely right, actually, and we're now starting to put in 5G boxes onto our networks because we can then reduce the network demand, because a lot of the time it was just scaled up to deal with peak loads. And actually, we just use 5G to supplement any peaks in demand, and therefore we can reduce costs that way. So, the point there is the technology landscape is shifting and allows you to do things differently and to look at the contracts that you're using and how you're spending them on differently. So there's examples of the sort of what we find in practice are things that you can pull to reduce costs. I'm sure you're familiar with a lot of those. Now, if that was easy, if it was easy to do, why wouldn't you do it? Well, the reality is that contracts, or the route to getting these addressable savings is going to lie through going to contracts. That's the easiest point to start with, looking at how you're using suppliers and adjusting the contracts or cancelling them. But you need to understand what the contracts are doing. Now, this is hard. It's always hard because, firstly, services, and I'm thinking here of some of the services, things like data centers and things like that. They are going to be specified, the service contracts are specified over a sprawl of interconnecting schedules. A typical contract will have something like 20 schedules, and they all interconnect. And And unfortunately, they're all inconsistent. If everybody stuck to the Cabinet Office guidelines, the Cabinet Office model template would be an awful lot easier because that provides a best practice template, but they don't. And actually, interpreting what's in each contract, particularly for the smaller ones, the lower value ones, can be quite hard. And actually, the relevant material that you need to look at to actually relates to cost savings, the things like the SLA tables and the schedule of charges are quite small, and it can actually be quite difficult to prize out of the bigger contract structure. So there's only about 10% of any contract you'd actually want to look at if you're assessing how to save costs. The other thing in there is it's not just the contracts you have to look at, because you're also trying to tie them up with what the invoices are, the extensions to the original contracts, the scope of work for projects that get set up and are run. So that all leads to quite a large body of documents that you need to look at and understand before you can make sensible decisions about how to cut costs and without killing the organization. And the last point in there is actually some of this stuff is pretty hard to find, particularly, and I'll use the ICS context here because that's what we're working with. ICSs are mergers of many organizations, as you know, and contracts are kept, they're not kept in one place. So really what it boils down to is to get it and understand the cost savings, it's quite hard. You've got to go through quite a lot of pain in terms of assessing those contracts. And sometimes, again, the sort of money you're talking about, it's not the big, that's the big, cap contract, which is worth 10 million, where you can easily identify it. There's a lot of low-hanging fruit, which might be embedded in the smaller contracts. So, this is where AI comes in, and this is where we've started to work. Well, we've already done it with one large consumer organization who are faced with this sort of problem, going, well, how do we actually get value out of our contracts? So we basically worked with them to build an AI agent, natural language processing, which ingested the contracts and was trained to look at those contracts and actually identify the bits which were going to be worthwhile looking at with an expert, people who actually understand the services and actually understand what it means. And what this meant was what previously would have taken months and months and months and was probably prohibitive sometimes, really, in terms of the cost savings you might get, could be reduced to weeks. Because really, at the front end, you're getting the AI to do something it's quite good at, which is just not falling asleep and when actually reading a large amount of text, and then extracting the relevant bits, or at least pointers to the relevant bits, whereby the human can then look at the interesting bits where you won't fall asleep, because that's things like service levels and annual monthly charges and things like that. So, it's still a work in progress, I should say. Sorry, I should come on to that in the next slide. But it's certainly, from what we've seen so far, it's a good approach to actually dealing with the challenge of, what was previously to be a lot of manual labor, to then actually allow effort to be focused. And actually, it probably makes going after, I say, some of the smaller, the long tail of contracts, if you like, where there will be, 100K saved here, 200K saved there, 20K saved there, more addressable, as it were, rather than necessarily just focusing on the really big contracts. On that one, yes, sorry, on it was Global Consumer Goods Company. They were global. And I probably just said already what we did. The one thing that also we did, which helped them, was that we gave them a capability which would be improved over time. I mean, because the thing about, as you probably know anyway about AI, the more data it sees, the better it gets at assessing things. So the natural language processing gets better with the more it sees. So we've given them a capability which is a start, which allows them to, and has addressed, in their case, over 35 million cash benefits. So that's quite big, but again, they're a very large-scale global consumer company. But they will be using that now on an ongoing basis to help better manage their contracts, and they will be looking at how contracts are used and how work orders are drawn down against. So it's not just a one-off cost-saving activity. They're looking to get soft costs by better management of their contract on an ongoing basis. So that's where it became interesting, at least where we picked up then and said, well, that's very promising, because if you're getting that sort of cost savings from a company with that approach, surely it could be relevant elsewhere. And at the moment, we're working with 2 ICSs at the very early stages, though, to try and, in the first case, run a series of sprints whereby we're, if you like, picking off some contracts which are likely to yield results. We're not at the point where we're trying to use our engine or train our engine on every document that they can find. We're honing in on, and again, it's a discussion, and it's about trying to get the balance right between where do we start, and that's a discussion that then allows us to go, right, we're now going to assemble the contracts and train the model, and then we'll learn from that in that context, build out, and improve the model that we can then roll out and apply to another ICS that we'll be working with. So at this stage, and it'd be lovely to be able to put up on screen, yes, here's what we've already done. The reality is, and it's probably an important reality check, is that even with AI, the data still needs to be assembled. It's not at the point where we're launching automated agents onto the network to wander around to find contracts. The material still has to be collected, which is a challenge. And I think I alluded to that in the earlier point about the challenge. The challenge of actually just finding the files is still there, and that's, I don't think there's a quick way around that at the moment. And I think by contrast with the consumer goods company, they had a very, very clear, quite well-defined document set that we could work on. So I think that's probably one of the learning points we're picking up on so far, is that even if you get AI to do some of the heavy lifting, there is still some preparation work that has to be done. But hopefully, when we're back next year, we'll be able to talk about the amazing cost savings we've managed to yield. Jenny, I think that's probably me done.
Brilliant. Well, morning, everybody. I'm Jenny Lewis, and I head up PA's health analytics practice. I'm a health data person through and through. I was an academic epidemiologist for a while, and I've spent the rest of my career working in and around NHS data, which is a very exciting place to be at the moment. We're first going to talk a bit about population health. I suspect that most of you are probably aware of this definition. It's been kicking around for a while now. Where population health management is a data-driven approach to planning and delivering proactive care to achieve maximum impact within collective resources. I think one of the things we're going to talk about today is, I think we've done quite a lot now on the data-driven approach and the planning and delivering proactive care, but what we've now got to do is get to the point where we're really starting to achieve maximum impact within the resources available to us. So the sort of wheel on the left-hand side breaks down a little bit what population health management is in practice. And I think one of the best examples of this is one we all know very well, which is the COVID vaccination programme, which was effectively an absolutely massive exercise in population health management. We had to start by understanding our population, which in this case was the entire population. We wanted to define our outcomes, which was predominantly we don't want people to die, and we want to have a workforce that can look after sick people. We needed to understand the variation in that. That was challenging. We had to change our views on that a lot as we got more information as the pandemic went on, but clearly older, more vulnerable people were far more likely to be seeing those outcomes than the rest of the population. That allowed us to risk stratify that population, segment it down to those populations that we were particularly concerned about, and then prioritise those. And that was the approach that we took around making sure that our workforce were amongst the earliest to be vaccinated, as were our elderly and vulnerable populations. The bit that's really interesting is matching those cohorts to the intervention. So I was co-leading the information cell at the centre of the vaccination programme. And we spent a lot of time talking about what are the interventions that we can use for each of these segments. And for workforce, it meant taking vaccinations into the workplace. That worked very well. For older people, it meant taking vaccinations into their homes at times. And again, that worked very well. And clearly, as the pandemic came on and we realised that there was other underlying variation, particularly in ethnic minorities, and the interventions needed for them were quite different. And the end of the population health management cycle is try out those interventions, see what works, iterate, and then amplify those ones where you're seeing good results. So that's pop health. This is an example which hopefully brings it to life at a local level, taken from the Place Development Programme, which was a programme that we ran with NHS England for a couple of years, working with every ICS actually to put in place a really clinically driven population health management intervention. This one was a PCN, and they already knew that they were particularly worried about their elderly population. This awful statistic that 25% of their over 85s had been to A&E at least once in the last year, which is clearly very bad for those individuals, but it's also extremely bad for the cost base of the system. We did some risk analysis of that population, so we were able to segment the data right down to those individuals, and we found that there were some really key risk factors, particularly around frailty, dementia, and also living alone. That's an interesting one. You can't get that out of NHS data. You have to link that into other data sources to find that out, but it was a really big factor in this case. What the PCN did was to then stratify down their population, get the list of people who were most at risk, and they were then put into an enhanced and earlier winter check process, and they had plans put in place to support them over the winter period. It was a really nice example of amplifying other programmes. There was already a virtual wards programme that was in place, and that was heavily targeted towards this population, as was a whole heap of voluntary sector contracts that they already had in place, very much making use of stuff that was already happening, and specifically helping to avoid the costs associated with those people declining. So there are some wonderful examples like that and many, many others of population health management techniques helping specific populations to lead much better lives and helping us to run our healthcare system better. What hasn't yet happened is that this stuff happens at scale. And I think that's at least partly because PHM for many, many years has been the domain of clinicians and data geeks like me. And I get very excited about it, and I love the fact we have linked data and we really can identify people at risk in such a better way than we ever could before. But what we really haven't done is link that to how are we going to help the NHS to continue to be a financially viable organisation. So what's on this slide is a piece of work that we did with a Place, and they were interested in assessing some interventions that they already had in the pipeline for out-of-hospital care. All of them were population-driven to some extent, and they wanted to know what the cost-benefit was that was associated with those. Interestingly, it wasn't a particularly easy thing to assess. There are not lots of at-scale case studies of this stuff working. So we took about 30, 40 case studies and applied them to 5 interventions in particular, and used that to assess both the cost of putting the interventions in and also the benefits that would be received. And there were some really obvious outcomes from this. So the first was they all came out net positive. So we were able to show a cash benefit for all of the interventions that this place were planning to put in place. The second, which is very obvious but I think important, was it does make a difference the size of the cohort that you're impacting. And that is often a tension. There's definitely a clinical side of population health management that says if you impact one person, that's a success of PHM. That's true. But if you really want to look at it from a finance perspective, you do need to consider the size of the cohort that you're impacting. So that was a really a big driver. And then I think the final bit was a lot of it was about cost avoidance. So it's targeting these members of our population who are going to decline, and if we can get to them early, the services mostly are already there to help them, and then that can stop us having costly impacts elsewhere in the system. This is just some numbers of some of the examples that came out of this. I think the bottom two might be particularly relevant given what Julian said yesterday about mental health. And these are both interventions where you're trying to make a link directly between a physical health service and a mental health service. The first one being putting mental health into primary care, and the second being putting primary care into mental health services. But some really big numbers falling out of this and proving that it is possible. This is still relatively small scale. We're now working with this ICS to build a whole ICS benefits model that really starts to show how these population-driven initiatives can be used to drive an entire financial strategy from population need, but trying to balance that desire that we have to put the right clinical interventions in place and make sure that these are cost-effective services. And my final slide on this, these are two examples of population-driven initiatives. These are, again, both from the Place Development Programme. And they're both ones where the cost of the intervention was incredibly low. So the one on the left-hand side is an area that wanted to look at their waiting list, had a hugely inflated orthopaedic waiting list. They knew people were waiting on there much longer than they should. And we were able to show with the data that they had some people on that waiting list who were at very high risk of ending up as emergency admissions into hospital. They used existing services around community support and physiotherapy in particular to help those people to wait well, and saw a really dramatic decline in the number of those patients who were needing emergency care. And the second one, which is probably my favourite, is another local area who they wanted to particularly look at their younger male populations who, it's well known, are at high risk of suicide, but they were a real outlier for this. And they didn't really understand it because they've got loads of interventions already in place for dealing with those type of individuals. So again, we had a look at the data, we found the people, we found that was absolutely true. There was a lot of people who were at high risk, and we identified those people, they went and spoke to them. And what they discovered was it wasn't that the services weren't there, it was that the communication channels weren't there. So these people just didn't know that this stuff existed. One of the main ways that it got communicated was through GP practices, and this is just a population that doesn't go to the GP. So they made some really, really small interventions around advertising these services in community centres and in gyms. That was one of the big impacts. And suddenly you've got a whole population who know about the services you've already set up for them, and they can now access those services. So that's what I was going to say on population health. The final topic before we go to some questions, we're going to talk a little bit about operational productivity. This is an area that I've been working in for at least 10 years now. And we've been using data to help organisations, particularly hospitals, just simply because they sit on so much data really, to drive productivity improvements. And I can certainly remember the time when it would take us something counted in months to get data out of a theatre system, to even be able to identify where the productivity opportunities were in that environment. And now, of course, we do it in days. And we're actually starting to be able to use the data to drive that productivity improvement, which is incredibly exciting. It's a result of increased digitisation of services. It's a result of, I think, an understanding of the importance of data, and we can get access to it now. And it's also a result of the wider world getting better at producing algorithms. I said earlier that I did a PhD in epidemiology about 15 years ago. And at the time I was coding in R and I was using some pretty advanced statistical modelling techniques. And now all of that is totally obsolete. The teams I work with now who build a lot of AI algorithms, I mean, they laugh when I tell them I built the models in structural occasion models in R. They're like, oh, so passé. But the fact is we can do things now that we just couldn't do a few years ago. So we've been really trying to push that forward recently, and on the screen now is what we call our Patient Catalyst suite of tools. These are all tools that take data that exists either in a hospital or a healthcare system, applies some sort of advanced analytics or AI to that data, and then specifically uses it to drive productivity improvement within the organisation. One of the things that I think has come out of this is we have realised, and I think the trusts we're working with have realised, just how complicated the decisions are that the operational staff are making on a day-to-day basis. There are huge variations in clinical pathways that go through a hospital. It's one of the things that makes a hospital so complicated. And we're expecting operational and very busy clinical staff to make rapid decisions about which patient gets treated when and where. It's not the clinical part we're trying to look at, it's the operational wrapper that sits around it. And it's an absolutely brilliant use case for how intelligent algorithms can help us to make those decisions. Just to give you a couple of examples. So this is an image from something we call our patient tracker. What it's doing is it's pulling together data from across the hospital, and then it's using it to create an elective pathway. So what you're looking at here is the entire workload of, in this case, hypothetical ENT department, all made up data. And along the middle, you may not be able to see it, but all of those blobs represent a different part of the referral pathway. So from referral all the way through outpatients, diagnostics, back into follow-up, through treatment, and then on the far right-hand side of the tracker, you can actually see the follow-up waiting list as well. Just because of the way our healthcare system has evolved, it's really, really difficult to get this view. So we manage outpatients, we manage diagnostics, we manage our theatres. We don't manage end-to-end elective pathways. So the first thing we've done is put all that data together. The next thing we've done is we've used algorithmic techniques to then be able to create those end-to-end pathways, and we can now see an entire workload in a single screen. I'm happy to go through any of the detail of this people afterwards, but the red blobs that you can see on the screen, those are patients who've been waiting longer and that part of the pathway than they should have been in order to hit waiting time targets, but also to give them the highest possible clinical care. And what we're now starting to do, now we've got this, is we can now predict along those pathways. So if you imagine this is a snapshot of your ENT department, we can now put some predictive analytics over it, which says this is what it's going to look like in 6 weeks' time, and these are the actions you need to take to stop these bottlenecks appearing. I'm going to bring this to life a little bit with an example. This is some work we did with Nottingham University Hospitals. It started back in sort of 6 months or so into the pandemic, so it's a bit old in its origination. But the issue that we were addressing was in diagnostics. And diagnostics is a thoroughly overlooked part of the organisation from a productivity perspective. Certainly, as someone who's been digging around in this data for many, many years, I've done very, very little in diagnostics till the last couple of years, where I think we were able to get at the data and people started to realise we could do something with it. So Nottingham are finding, as every trust was at the time, that there was a huge increase in demand for diagnostics after that period, immediately after COVID, when pretty much all diagnostic services stopped. We worked with them to do two things. First thing we did was to help them to understand how to make their processes more efficient. So it was all about changing the structures of meetings and behaviours and all of that good stuff, which is incredibly important. And the second thing we did was to provide them with some tooling that helped them with the booking of patients into their scanners. And this is another really good example of extremely complex decision-making that's happening in hospitals every day. I was shocked, actually. I had no idea how complicated it was to work out which patient from a waiting list can go into which slot, in which scanner, on which day, with which people. It was so complicated that there were bits of it that could only be managed by a single person who'd been doing it for the last 20 years and really knew how to do it. So we gathered all of that data together. We created the algorithms that allowed that matching to happen. So they were able to say, right, this is my most important patient. What's the next slot I can put that patient into? And similarly, they were able to say, I need to book someone into this slot. What's the best prioritised patient? And it would tell them which the best patient was. So we're now going to try and do something technical and switch over to a video. We made this for an HSJ award application we put in last year, I think, where we were finalists. And you're going to hear from four people from the trust. So David Campion, who at the time was running diagnostics, Kath Halliday, who is the clinical director for radiology, and two of the individuals who are involved in the booking process, Alex and Stephanie. And hopefully it will bring to life for you a little bit what this looks like, if we can make the switch.
Innovation and new processes means that we're confident, we're maximising the use of the resources we've got, which is really important because we can't just grow ourselves out of this. The workforce isn't there to just continually expand.
What this tool does for us is it enables us to use all our sessions as efficiently as possible.
We have moved away from our sonographer name lists, and we now have our sonographers assigned to categories based on their skills. This was then used to create a rolling router, which means that our diaries are open much further in advance than before.
Patients are being seen quicker, they're waiting less time for their diagnostics, which is supporting them on their onward journey.
So hopefully that brings to life a little bit what I've been talking about. What you can see at the bottom of this slide is what we saw the impact was in numbers, and it was pretty startling. We were really able to see a significant increase in use of the capacity of these scanners. We've now done similar work with a number of organisations, and we have always found underuse in diagnostic scanners. I really think it's a very overlooked area for potential productivity improvements. The Trust have managed to sustain this. We were looking at their numbers just the other day, and their forward bookings are looking really, really strong. So that's an example of hopefully brings that to life a little bit. Just before I close, a few lessons, I guess, that we've learned over the years of how do you get data to really work in an organisation. Number one is by far and away the most important. If you can get a clinician to drive and run this, it will be infinitely more successful. You've just heard from Kath, she was absolutely instrumental in the work that we did for that imaging example, and it has always been true. I have never run a project, a successful project that didn't have at the centre of it a clinician who really wanted to do it, who got it, and who understood, and it's worth spending the time with those people. The second is understand why they're doing it. All of this work requires behaviour change. I think it is, we would be naive to think that as we go on this digital and data journey, every step is going to be equivalent to when tablets got introduced, and we were all like, oh, this amazing thing, and everybody jumped on it. Although arguably there were still laggards. We are going to have to help people to understand the benefits of these things, and again, taking the time to explain to people why we're asking them to change their processes and their behaviours and what benefit this will bring to them is really important. A significant focus on implementation. If these are digital and data-led projects, they will fail. They need to be operationally and clinically led, supported by your digital and data teams. And then the final one is about positive reinforcement. It is absolutely guaranteed that if you start to dig around in the data in your organisation, you'll find a whole load of gremlins. Data quality is still a problem, and it just will happen, and you need to plan for that, embrace that. And the brilliant thing is that these projects, as a side benefit, will leave you with much better data quality at the end of it. And if you can help people to understand the benefit that they're getting from that, they'll engage with it, and suddenly you've got your data quality getting better and better and better. And we can start to do even more exciting things with the data that you're sitting on. Thank you.
Thank you, Jenny. Right, I think we've got a little bit of time for some questions. So, what questions do you have? I've got a couple I can start us off. Oh, there's one over there. Let's go for it.
Yeah, of course, yeah. I'm Richard Chapman. I'm the Chief Finance Officer for NHS Frimley ICB. Just to the first speaker, we are in the process of moving to a contract management tool called Atomis, which I think is widely used. It's sponsored by DHSC and paid for until 2025 by the Department for Health. I think there's about 190 NHS organisations currently on it. I'm just wondering if that gives an opportunity perhaps to do the things that you were describing once nationally. So the overlaps in contracts, the over procurement of licenses, all that type of stuff, we're all on the same system. Is there a route there to writing the AI that you need to do that analytical piece once in the same way as you did it for that global I can't remember what you said it was, but the global company.
Yeah. We're familiar with that database. In fact, actually, that was actually the starting point for some of the analysis that we actually did, to say, well, actually, look, where are the pots of money that would be worthwhile analysing and looking at in depth. So I think that certainly helps in the initial scoping. I don't think what it does do is actually allow you to really deep dive into how some of the contracts are actually put together. So when you're starting to do things like, for example, look at how the service levels are defined, and within then pick that out and go, well, are you over-specifying here? Are you over-specifying there? So I think some of the nuts and bolts of when you're actually trying to pick out the contract and go, well, how is it working to deliver service still has to be, that's the conversation that needs to be had to go beyond some of the things like, well, actually this one's due for renewal and this is the time to think about it. It helps with the targeting. So as another, to build on that slightly is, there is getting to the addressable spend means making the most of the opportunity, particularly starting at the right time. So if you've got a contract which is due for renewal in a year and you have an option for extension, it's the database is good for isolating that contract, which then allows you, well, look, this is the chance we've got now to look at how we've used that contract in the past. How have we defined statements of work? What's the pattern that allows us then to inform the procurement, which will allow us to get a better version of the service of the contract. And it may even be going to the same supplier. It may be a case of going, well, you've done this work for us and that's great, but actually there are things we now want to change. Version 2 will work a lot better because we've got a lot better view. And that's part of what the process is about looking at and going, well, now we have a chance to do something differently. So the short answer is the database you mentioned is good and a very useful tool, but it's going to the next level, I think, where the AI is starting to be useful.
Thank you. Duncan, just the back.
Hello, Duncan Orme, previously Chief Finance Officer at Nottingham. Jenny, thanks for your presentation. It's good to see you, and it was great to work with your team. I had two thoughts as you were describing back the work there that the team had done, and putting it in the context of also the wider population health work that your team has been involved in elsewhere. The first was to emphasise the impact that I certainly saw from the clinicians to say this wasn't just about productivity, especially on the cancer pathways. This was about saving lives. And they were identifying people who were dropping off and becoming invisible without that. And it was one of those projects really where you found so many people when they got it understanding that. But the two difficulties that I saw in it was first getting people to understand that and engage, which you picked up. But the other from the boardroom was how you convinced the board that this was something that was worth doing. So we started our journey pretty much during the pandemic, where it was easier to make this investment. Now, in a time of really quite dreadful austerity, getting these investments through the board is going to be harder. And so my question would be, what advice have you got about pulling together an information strategy which will back some of this up? I sense from the presentation lots of strands, but that ability to support a CFO or a finance director to make the case in the boardroom, I think is still work to be got into.
Yeah, I totally agree, Duncan, and good to see you too. And I think part of this, as you say, is the move out of the pandemic. We went through a period of about 18 months or so where we probably made more advancements in the way we were using data than we have in, I don't know, decades. It was an amazing time to be somebody who spends their days analysing NHS data. And we're not there anymore. We're now right back to the point where all of these investments have to be justified, and we need to be able to show the link between the benefits that we're getting from these systems and the financial position of the NHS. I feel quite similarly about it on the productivity side and the population health side. Pop health has been like this for a long time, where we all know it's the right thing to do, but we haven't been able to get the financial position to support that. And I think this huge increase we've seen in the last couple of years of what we can do on the operational side, we've got the same challenge. We now need to be able to show that back. We're doing a lot of work at that at the moment, because we want to be able to continue to take this work that we've done and accelerate it out. And it's absolutely linked to how can we show that the implementation of use of tooling of the type that I've just described to you will drive positive benefits for the NHS. And there's sort of two parts to that. There's the reduction in administrative effort and complexity that sits around that. But the far, far bigger prize is you are treating more patients in places where they should be being treated. And that's the bit where we need to focus on as we pull those strategies together.
I promise not to talk about run rate, but I think there's an in-year payback as well for some of these, isn't there?
Yeah, there should be, absolutely, yeah.
Okay.
Hi, thank you. So I'm Guy Dentith, I'm CFO at Dartford and Gravesham, and apologies, my voice is a bit sensitive this morning for some reason. On the theme of natural language processing and using that for contract management, I'm very aware a lot of the contracts that I'm asked to sign off are not in remotely natural language, they're in impenetrable legalese. And I wondered, so one of the question is, does that cause any issues, or is that actually part of the benefit, I suppose? Because actually having something that could radically simplify a lot of the contracts that we have and bring out some of the KPIs and all the things that you were talking about to bring out and have some of that in plain English, beyond IT contracts to PFI to all sorts of a whole host of impenetrable contracts we're all sat with, would be really, really helpful. So just be interested in your views.
Yeah, I think I like that term. It isn't natural language, is it, in many contracts? The answer is we need to ingest and train and learn, because, you know, we've done a few now, and it gets better as you go along with the more contracts. And as you say, you know, it's another language, so therefore exposure to that language and understanding, and then just helps refine it. So certainly, you know, we're doing more IT contracts this time around than we did with the consumer one. And we're already, you know, I think to be productive, you need, so for example, for data center services, it starts to be more interesting once it's absorbed 3 or 4 contracts, and then it starts to get sensible and starts to be more useful. So training is you know, you have to factor that in. It's not like we can suddenly go in and go, well, here's a brand new type of contract for a type of service, go off and do it. No, you need 3 or 4 and then to bring it up. But hopefully, and again, this is the cross fingers moment, you know, when we do a few more, it then does get better and better, and you know, it needs less human intervention, as it were. So that will be the promise. I'll be interested to know myself how well that works.
Any more? Paul?
I was just wondering whether you think the NHS is behind or ahead of the rest of the world in terms of application of AI.
That's a great question. Jenny, do you want to start on that one?
I think it's almost certainly behind. I think we have a lot of advantages as because we are effectively one system. We can get access to quite a lot of data, and things like ICS level analysis, even national level analysis, is things that other countries just have absolutely no ability to do, because they are individual organisations. They can't link it together. Investment in it, though, in the NHS has been very, very low comparison to other systems. And by it, I mean the digitisation of the systems, so people are entering good enough data that you can do something with it, and then investment in the data platforms that then can extract the data into and have some chance of running these algorithms over it. So for those two reasons, I think we're probably behind. But the reason I'm slightly hesitating is the acceleration over the last few years has been so great. And I think if we'd asked ourselves this question pre-pandemic, the answer would have been absolutely we're behind. And we clearly are accelerating that. The other thing that I think will make a big impact is the growth of trusted research environments. So that is going to get our academics access to data safely and sensibly in a way that's never been possible before. That's really exciting. That will start to mean that we could potentially become world leading, I would suggest, in this stuff.
Brilliant. I think we're just down here.
Yeah, thank you. This on David Chandler from North East North Cumbria ICB. Just a quick one, actually. The case study that you gave on mental health and suicide. I was just interested. I mean, it was all interesting, and thank you for the morning session. But I was just wondering on that one, which area was that, and those interventions that you talked about. Did you see a sustained impact in terms of number of suicides? I get the numbers can be quite low. And the reason I ask is just because in one of my patches in Middlesbrough, I think it's got the highest suicide rate in the country. So I'm just wondering what the long-term benefits were from that intervention.
So, yeah, really good question. That is exactly what we're starting to measure now. So that population health cycle that I showed at the start, which ends with do the intervention and then evaluate it, that evaluation is ongoing for pretty much all of the case studies I presented today, actually. So we don't know yet. Anecdotally, that one has been particularly positive in that they've seen an increase in engagement from the population that they were looking for into the services that they were interested in. Obviously, the hard outcome they're looking for is a drop in their suicide rates. The other bit that's interesting about that whole topic is that suicide, or frankly death, mortality as a metric is a really hard endpoint, and it's a very infrequent event in almost everything you'd want to measure. So although we use it a lot in a healthcare setting, and it's been a clinical outcome measure that's been used for years, and it is important, we mustn't forget it. What is almost more important are the metrics that sit around it. So, and in this case, what we're interested in is diagnosis of the conditions that might precede some of those things. So that's the other thing they're looking into, is how can they get better access to those leading indicators that their end point will be reached. But very much an ongoing exercise at the moment.
Can I ask you which area is it?
I can't say that now, but I can talk to you afterwards. Yeah.
Brilliant. I think that is pretty much our time. But me, Jenny, Alastair, we're all here all day. So, if you want to come and ask us more questions, collar us. We're always really happy to chat. Thanks for your time. Hopefully you've seen a few of the incredible, really, use cases for AI and new technologies in healthcare. I think you can tell we're super excited about it. So, yeah, if you get us started on it, we won't stop talking. We've been PA. Really great to see you all, and have a great day.